welcome. It's my pleasure to introduce this very, very attractive webinar particularly for patients. And the title is Doctor, Can You Ask Me? This is very intriguing and stimulating condition.
It's 16 hours.
We have two speakers, very expert on management of the health of patients. The first one is Magdalena Chupera, that is EPAG for Air Reconnect and representative of MCTD, Mexican Connective Tissue Disease. She's an English teacher by education and an experienced manager on hospitality sectors in his hospital. Is a part of a Three Mimzie Razem, that is a patient organization in Warsaw, Poland, where she comes from. And the second speaker is Vera Ramesh, that is another EPAG representative, and she's representative also of the mixed connective tissue disease. She lives in Vila Franca de Xira, near Lisbon, and is a clinical psychologist at Vila Franca de Xira Hospital in a unit of oncology and member of a palliative care team. Vera, unfortunately, has been living with this disease that she knows very well since 2007, when she was diagnosed. And she has experience in helping patients with chronic disease, which are coping with their chronicity, as psychotherapy in particular. She's also an active EULAR patient research partner, the European Society of Rheumatology. So I would like to invite this very interesting answer between the two speakers, and you will invite yourself to give yourself some questions. And so please, Magdalena, you can start. Up to you. Thank you.
Thank you so much. Welcome, everybody. And it's really nice to be here. What I would like to do first is to share our presentation on communication. So let me do that. And you already know who we are. Thank you, Maurizio, for introducing us. And today we are going to talk about what kind of questions we expect from doctors, but maybe not only doctors, to ask us. Now, we've talked a lot about the importance of doctor-patient communication, but this is something that we still would like to concentrate on. Why? Because as it will come out from this webinar, it has got huge impact on patient outcomes. And what we today would like to concentrate on is therapeutic relationship, or what we call a therapeutic alliance, something that may start or may improve between us.
Hello, you all. I am Vera Guimarães, and I will think with Magda about this important theme and important issue. So let's think about this that just Magdalena talked about. This therapeutic relationship or alliance, it's very, very important in many social sciences, psychological sciences, but sometimes it's forgotten in the relationship of doctor-patient or HP patient. It's also very important for these reasons you can see on the slide. But let's think together. There are questions that all doctors or HPs can ask and will ask. They are easy questions. They will do it. But there are some questions that only a few HPs or a few doctors will ask because they're a little bit difficult, a little bit harder to question the patient. So let's think why this happens with me, if I am a doctor, or with me, if I am a patient. So let's think. Even one question can change the course of the communication between HPs and patient. Even one question can improve the relationship and the alliance between the health professional and the patient. So why so hard for us to achieve this kind of goals?
Now, we've done some research. So, not to bore you with too much text, I just want to revise and give you a briefing on a few articles that we have found in medical publications. So, what we have discovered is that communication between patients and their physicians is really important because there are a lot of expectations, there is a lot of stress, but it may actually improve the outcomes later. For example, one of the articles says about fatigue. It is stated that 77% of patients lack of such a question about the fatigue, but then they have to initiate these questions themselves. So the conclusion here might be that maybe in some ways doctors might be more proactive when addressing some symptoms because we patients sometimes we don't know that we are supposed to know about our conditions. Another article says about the participation in and involvement in decision making, especially medical decision making, and it turns out that it is based on our age, our involvement in, for example, self-help groups. So such patients will be more aware, more educated, and probably they will want to have participation in decision making, whereas the others might not. So again, the question to doctors is how to address, how to assess even the patients so that we can have this tailored communication system and decide together, or maybe decide sometimes for the patient in some cases. Another article says about communication. For example, there are 40% of patients who do not feel secure in the environment that the doctors create, and they feel that they are at the risk of suboptimal communication environment. And what they say is that because of that, they do not say something about their symptoms, so they underreport the symptoms. They also are afraid to ask questions. And what it comes later, they are afraid of being judged. But basically, what we can come out of this research is this, that effective physician-patient communication in rheumatology is linked to improved patient outcomes. So this is what's important for us. Everywhere, what is underscored is direct communication, environment for open dialogues, and comfort that we can give to patients.
So that's it. So research tells us a lot. And this is just a small part of the research that we are showing you. So there are a lot of more research saying this really improves patient outcomes. And there also is research saying the same in the social sciences, in the educational sciences, and in the psychological sciences. So if this is what research tell us, so let's think, why don't we use this knowledge in our daily work, in our units of work, where we are patients, where we are professionals? So let's think a little bit more why this happens. Why don't we use more this power of communication?
And we call it chronic communication gap because we've been talking about it, seems like forever now. The common issue that we have to struggle with, including time constraints, medical jargon, lack of involvement, lack of training in communication, and so on and so forth. But the consequences could be really serious, such as misdiagnosis, dissatisfaction, non-adherence. And what is very important for us is this low patient education.
So let's think again together. Why this communication gap that has always been there with humans since days back and will continue to the future? So if this is a reality and we know this happens, so why don't we are more aware of it? So this is why we are talking about this. So remember, there is not only the communication gap, there is also the personality traits of each person: nurse, doctor, patient, another health professional. It has its own gaps, its own personal constraints. So, and we also are human, so we are not the same all the time. We are not communicating as well when we are sick or when we are concerned with something, or like Magda said, when we have lack of time to be with the patient, or when we have lack of training, because this is not enough just to speak or just to be aware of this chronic communication gap. We have to train how to be better in communicating. So take note for yourself of this chronic communication gap when we try to engage a better communication with chronic patients. So
Mhm.
let's not forget that we have to be in more resourceful
Yes,
strategies to
right,
achieve a better communication.
right. If we have such little time, let's train how to use it effectively. Now, about the questions. We have some tips for you too, but is there a list of right questions? Can I ask better? So, not only doctors, but we just say about all HPs, their questions shape patients' responses. We have to be aware of that. But patients' questions also might shape HP's responses. Let's use more open ended questions. Empathy and active listening is the key here. And more importantly, share agendas. Both sides have agendas. And I just would like to draw attention to this drawing, to this picture, because we have to remember that we do have two different angles, two different perspectives. Something that might look one way will look differently on the other side. We have to remember that.
Yeah, it's a good picture that keeps in our heads because we don't see the same. I don't know if Magda is seeing the 6 or she's seeing the 9. And when we are talking about hard, difficult things in patient lives, maybe the patient is not seeing what you are seeing as a professional. So, to this question, this important question, how can I ask better? Is there a list of right questions? Probably the better and polite answer is no. There is no perfect list or there is no perfect right questions, because what is right for Magda could not be right for Maria or for Jose. So the right way to ask a question is in the relationship between the health professional, the context in which they are, and with that patient in that moment of his or her life. So these kind of tips, more open-ended questions, is so huge and important. But don't just open the question. You have to summarize the information, kind of repeat the information to ask what was understood by the message that you sent. And it's really important because the patient is in fear, concern, whatever, and he might not have understood something that is really important for you that he has understood. So listen also to the non-verbal cues, non-verbal behavior when you are communicating, because that is active listening, not just listening, but seeing the non-verbal behavior. So let's think together. Do I think about my questions? Do I think about how can I ask better? Do I think about a communication gap between me and the other person? Do I stop in the communication to listen just a few seconds? Do I share my agenda with the patient? Like today, I was thinking to discuss this with you. Can we? It's okay for you. Can we do it? Ask. Did I ask the agenda to the patient? What were you thinking to discuss with me today? Let's share agendas and to see if the 6 is a 6 and the 9 is a 9, and share our point of objectives. in this case. So consider this carefully. What is my agenda? What is the patient agenda for today? And let's reflect. And the same goes for the patient. Did I ask what I really wanted to ask? Did I listen and wait in silence for the full communication of the HP? Did I share my agenda? So, did I make myself heard, for instance? So, the relation is between two persons. So, did both the two persons question themselves about their communication?
And this is a little bit the revising what Vera has already said, that we've got some common tips for the effective communication. First is use simple non-medical language. Adjust. So we talk about layman language nowadays, not only medical environment, but also legal environment. I think it's really worth reconsidering and learning. Vera mentioned pauses. We should use pauses. We should stop for listening. So silence is good. Sometimes some say that silence is gold. Use it for listening. Sometimes it could be very effective and very powerful. Allow time for patients' questions. If it's possible, use visual aids or written instructions. Many times we are visual people. We prefer or when we see something, right? We understand more when we see something. Summarize, repeat, ask again and again.
That's it. Uh, we all have listened this kind of common tips, but do you really use it on your daily practice or daily lives? You can even try this with your family. So it, sometimes you might think you adjust your language, but you have to acknowledge if the patient feels you adjust your language and if he is understanding properly.
Yeah.
The pauses, sometimes doctors say to me that the pauses, the silence is really hard. It's really difficult to be in silent in front of a person that is suffering or asking for solutions for a chronic and very hard disease. MCTD is no joke. So it's really hard. So I think sometimes we don't train as much that we need, but we know the common tips. We know there are some tips that we can use. And I would also like to make you think about that are you afford to stop your communication and to have a little time to adjust, to breathe, and to get acquainted with the patient. Sometimes you don't have the time you need, but think just a few seconds, just a few, half a minute sometimes, may be the time enough for the patient to speak up and say something that is really concerned about. Sometimes that really happens to me with older persons that speak more slowly or have some kind of impairment. So we really have to wait. And sometimes doctors are surprised if they wait, the people will communicate, the person will communicate better or will communicate. But we have to adjust ourselves to their characteristics. For instance, I said older persons, but could be personality traits or other thing. So share your agendas, be truthful with your time, may apologize because you could not have all the time you want. Be truthful about that and share your constraints and your difficulties with the patient. Sometimes that will be interesting for him to listen also your difficulties.
So now we've got some questions ready made. Doctor, can you ask me like this? These are our expectations. How have you been feeling today, or since last week, or since our last visit? What concerns you most about your condition at present? Do you feel comfortable with the treatment plan that we have discussed? Is there anything else you'd like to ask? And the last question is about being a living person, being a human. In fact, what life projects are you involved in that may collide with our treatment plan? Nobody asks us about that. But we do have life projects, we do have work, we do have private life. But sometimes we have to put everything aside because the treatment plan requires this. But is it really like this? Should it really be like that?
Yeah. For instance, imagine that you will do some treatment plan that enables you to get pregnant, and your life project was to get pregnant. So it's an important question to know which life projects you are involved in right now. So it's really a important question and an open question, and the patient might not answer if he doesn't want, or you can answer if you really wants to do it. It's an open question. So here I will try to ask you to think. Sometimes you ask some really deep questions. So kind of be polite. Can I ask you this question? Kind of ask for consent and feel if the patient wants to go in that kind of question. You don't ask can you share with me this and this? Ask first, can I ask you about this pregnancy objective? Do you want to talk about that life project with me today? And that is really important to feel this kind of consent and permission. This makes good communication between patient and doctors, and the therapeutic relations begins and starts to be stronger, and that leads to better outcomes and to better treatment plans with your doctors.
Now, we would like to invite you for asking questions as patients as ourselves. So, doctor, can I ask you? Remember that this is a relationship, this is alliance. So, not only do we have expectations from the doctors to ask us certain questions, but we would like to be able to ask questions as well. Here are some examples. Why is my body changing? Will I be able to work again? What if I don't consent? In the center, we put this don't be afraid to ask. So we wouldn't like to be afraid to ask questions within the doctor-patient environment. This is really, really important for us.
So you can see some of difficult questions in this slide, but I would like to ask you in the audience, the people that are listen to us, if you can write down in the chat some example of some
Other
question that
questions,
could be
yes.
hard for you to ask as a doctor or a professional or as a patient. If you
Mhm.
do that, we can read here and can share with others. So
Yeah.
let's see if somebody can put any question, or we can give examples, of course. But one big and huge example that sometimes patients are concerning is the sexual life and the pregnancy life. And sometimes it's hard to address that kind of questions in a therapeutic relation. But like Magda said, if the relation is strong and built together, then this kind of hard questions can arise. So if you put some question, we could address them later.
If I may just add, Lupus Group has initiated consultation cards. So they are preparing set of questions for the doctors not to forget to ask. And we are inviting you right now to ask some more questions, and maybe, just maybe, this would be a good idea to include them in such a consultation card, because we often forget or we are afraid. But if something is written, we get prepared, we feel prepared, and we feel more confident when we go to a doctor and we want to ask about something really personal. So that would be pretty effective. Now, benefits. How can we benefit not only patients but also doctors? So, of course, we can increase trust in healthcare providers. We can understand better diagnosis and treatments. There will be higher adherence. There will be improved healthcare experience, increased patient education. This is something that is really important for us. We've got better quality of life. And of course, we do not forget about mental health, which also will be improved after we get better therapeutic alliance.
And mental health relates a lot with my professional life, so it's another area of very difficult questioning between doctors and health professionals and patients. It's very hard to ask this area of health. So and if we are not trained, it's really difficult sometimes. But don't be afraid to try to use at least some kind of open questions, like how are you feeling about this treatment, or how are you feeling about this symptom very hard you to to manage, for instance. So it's sometimes really difficult to address some areas than others, but each doctor has his own strategies and difficulties. In this reflection, how can patients benefit or doctors benefit? Um, these words that are in these slides are so important, because with no trust, the patient will not adhere, will not do what you ask him to do. So trust comes from what? Communication? No, comes from the relationship built on communication. So that's why on our first slide we talked about therapeutic relation. This is really important to build this trust, and for the doctors to feel, of course, also in trust with this patient. Um, if I don't trust, I will not do something, and probably I will lie to my doctor, and that's not good, not for me and not for the doctor. So the trust is some kind of how do you say, very strong pillar for us.
Yeah.
In in the reflection, what can you do to get more benefit from communication? So you have always to be on reflection, how to gain this increased patient education, to gain this higher adherence. You have to build this, you have to give patient education. So this is very hard and time consuming, but it has really benefits that will have products in the end.
Now, I would like to draw your attention to encouraging patients to speak up. So patient education is something that we've mentioned a couple of times, because if patient is aware of their illness, is educated enough, then they will be able to express concerns more effectively. What is also important is creating a safe space for open dialogue, and then addressing cultural and language barriers. But let me tell you something about the safe space. I'm going to give you two examples. One is pretty negative, the other is quite positive. This is my personal experience when I was admitted to hospital, and a nurse, there was a preliminary interview with me. She provided this interview with me on the corridor, and I felt really humiliated when everybody was passing by me and could hear my very personal answers. And I could hear the questions, even about pregnancy and, other very, very touching and personal stuff. However, this was really dreadful situation for me to be on the corridor. I think it would be enough just to apologize. Listen, this is the conditions that we have got, and the patient will understand that there is no other way that we could do this. However, the space was not safe, but telling me or apologize me as a patient that this is the only condition, my understanding will or would make this space safer, to be honest. And there is another example I would like to draw to your attention. because this is what Marzena Olesińska, who is our MCTD coordinator, introduced in our hospital. She runs the clinic of connective tissue diseases in Warsaw. And instead of going rounds to patients with all the crowd of students and doctors and all the patients listening to your answers or listening to what the doctors have to say, she decided to organize consultancy room, consultancy office. So now one patient comes to her office when all the doctors sit and they will discuss only your case, which I thought it was brilliant because it creates a really private and safe space. You know that the doctors devote time only on yourself, they discuss only your case, and they brainstorm what to do with you and what would be the effective treatment plan for the future. And you are there with them only. No other patients, no other staff can listen to what they're saying. I think this is perfect, a best practice or best practice example.
Yeah, wonderful, Magda, because we have the bad for creating a bad space and we have also good solutions. But
Yep,
I understand because I work in a hospital that it's
yep,
not easy to provide a safe space. But that idea that you talked about, apologizing because I don't have a better condition to offer you, could work really well, like empathy with your patient.
yep,
And like pulling a chair if we don't have a safe space, we can search for a chair, we can search for a curtain and pull on the curtain if we don't have a door. Of course, I always say the door is better, curtain is less, and then we have chairs and sit down with the patient. It's really not a secure environment to have someone really tall talking us what to do in us patients in the bed. So try to be on their level. That I saw in the exchange program in Lille, provided here by the ERN Reconnect. And I really saw live these good safe space strategies that always sit down with the patient and always pull a curtain and create safe space like you were talking about, Marjana. But I also want to say a small word about patient education. We know and doctors know lots of programs about patient education in very known diseases like diabetes, obesity, like caregivers of dementia. But we don't talk so much in these diseases, rheumatic and connective tissue diseases. And it's also important in these diseases to have patient education because we will give outcomes to the doctors and better outcomes. So, and a bad one, it's don't talk about the patient like he's not there. There still exists in some countries, in some facilities, the patient is there and you are talking with a colleague like he's not there. It's not a very good way to create a relationship and a good and safe one. And of course, we will not address the cultural and language, but it's also a reality in several countries because of different cultural, religious, and other barriers. But we have to address that.
we just would like to finish with this kind of conclusion that when we have got one patient plus one doctor, we have got one story. And this one story is actually our unique relationship, our therapeutic alliance.
Yeah, that's it. So it's true. It's not easy to make a webinar or course or training communication course that will be perfect. You have to train with your patient in your consultation, with your characteristics and your personal traits. You have one patient, one doctor, it's one relationship. So in 2 months, 1 year, your relationship will probably change because humans change, but it still continues to be unique in your relationship. So it's really wonderful to be humans. It's really wonderful to do to help patients and to address people's lives. It's hard. Communication is difficult, but you can reflect on that and you can get better and better and better on relationship with patients.
So we have to remember that we
Yeah.
both play a role, both doctors and patients. And Vera, simple question can change a
A
patient's
simple
health.
question, yeah, can change a
Right.
patient's self-care journey. A good and simple could lead the patient in a good way or can take him off of your way. So it's really important the way you interact with patients.
Thank you so much for your attention now.
Thank you.
Do you know
Okay.
if we have any reaction or questions?
Okay. Okay. Do you have a further inter exchange of question and answer, or we can start to do some little conclusion to this
Please,
very
please do.
exciting inter exchange? Uh, I would like to discuss for you with you the terminology education of the patient, because every time I listen for patients, this terminology education, in my opinion, is a little
Mhm,
strong.
mhm,
It seems that we speak with people they are not generally well educated to understand, to learn, to be capable to survive to the diagnosis. I must educate you. In my opinion, the terminology education should be substituted with something like information and instruction. I would like to inform about your disease and instruct how to behave, how to improve the time you will spend for the therapy, for the rehabilitation in this case, or even for other important, the style of life, the correct diet. So all this, sometimes we forget this. The patient
Yeah,
don't ask. May have a special diet, may have a special quality of life, because if you ask to them what you eat, what you do you gym, do you, they answer. But usually nobody, no doctor, no answer, no patient explain their style of life or their style even related to the nutrition and many other aspects. So I think two important aspects, instruction and information about your disease and all what is lacking in your disease, because the disease probably sometimes is due to some mistakes in your style of life, something that you have not done because nobody informed you. That is a prevention of the disease. The prevention is the best medicine today we want,
yeah.
together
I
with
can
the
speak a bit
personalized
about that if
medicine.
you want.
Yes, yes, yes. So
Yeah,
I,
that's there are a lot of research on that
yeah,
on the changing of behavior. For instance, we can use like in my practice, lung cancer. We
yeah,
doctors say don't smoke, and the people smoke. So patient education is like you said, it's about giving information, but it's not just about instructions because the patients will not stop smoking because the doctor said to him don't smoke.
yeah,
Actually, the cigarettes have cancer pictures on the the pack, and people still smoke. So that's why it's really important, like in Lille, with the doctor Erika Ashula. That's really interesting the way he does patient education, that is transforming the mind. It's transforming information, not something that comes from the outside, from the nurse or the doctor, but it do it on a way. It's a program, of course, but then the patient knowledge grows inside of him, and that we call it in psychology changing behavior. We only can change a behavior inside some people had, not by telling him not to do, but to make him a cognitive difference. And that's it's all about this webinar. It's really interesting what you said, Mauricio, because all the doctors at this question and this problem with low education patient, and that's why the programs have done everything for the patient. Like I said, diabetes program, some people did not know what is diabetes, what to eat, and what to do with insulin, how to use the pen, and now all the people in the world can do it because of the program with the nurses, and they can do it in a village, in a small town, with low education, high education. So it's all about programs, and the programs have in research have better results than just information, pure and simple, because that don't work. That really, and you know, as a doctor, that don't work.
Exactly. When I say information, and that's what I mean. Information about programs, about capability to learn about the disease. So it's education, okay, but it's information. Because if you say just you risk cancer, it's too generic. But if
Yes.
you start to say there is a program which show that 80% of long-time smoker get cancer, it's a reality. Now,
Yeah.
probably when you do the steps, you have some problems. So you put the patient in front of their reality. Simple example, they start to be worried. And so then you offer the program what you want, of course. You offer an X-ray of the thorax, respiratory lung function analysis. But what is important is to inform them that there are, okay, program, but also easy symptoms that may be preventive, prodromic to the development of the serious consequence. That's, you mentioned it, just smoke, but
Yeah.
everything as a pre-aura, no, as an initial symptoms, and the patient they don't realize because we don't explain very well. Do you
Yeah.
have this problem? Do you sleep frequently after foods? This is a good sign. No, it's not good signal.
Mhm.
Maybe your blood is too dense. You smoke too much fat in your blood, you eat too fat. So, I mean, the doctor must be very practical at the beginning to create interest from the patient, from real life, and not
But this is, if I
theoretical, but
may,
real
yeah.
life.
But
I
if
don't
I
know what
may,
you think
yeah.
also, Magdalena.
Well, education is about learning, in fact, and maybe this is the approach of the doctors, because from what I hear, and also when I got into ERN and all the associations of patients, we had to get educated because doctors communicated to us in a medical language, which we could not
I
understand
know.
many a
Yeah.
time. That's
Right.
why this is education. What is education about, you know?
Right.
So
But
this
this
is
is
not only
education for the doctors. Not
Ah,
the-
there you go. So maybe you see, this is how we communicate, right? This is what we can change even in naming something. So if you stop using medical language to us, then we will stop using educational programs. Do you know what I mean?
Yeah, absolutely.
Because for you, it's a normal language. You feel it.
I
You
know.
like for you, it's something that
Yeah,
you
yeah,
use
yeah, yeah.
on daily basis, and we don't.
This-
And for us, yeah, you just said about the density of your blood, and I might not have an idea what that is all about and what are the consequences of this. For me, this is education. You know what I mean?
Yeah. But you
Yeah,
are right,
very
because even the doctors sometimes they don't know the mechanism of action, where's the target of the therapy they give. And so the
Right.
patient cannot understand why this or not this one. And they read on the internet, this is better, this is worse, but they don't know nothing about in their condition, in their step of the disease at the beginning, the early, late disease, is the best approach. They read
Yeah.
just an information. And sometimes, unfortunately, the doctor, they don't optimize the treatment and explain to the patient why not this and why this. This is a real problem. Today, we have thousands of drugs, very potent target therapies, biological drugs that act inside the body. And this is really dangerous sometimes, create
But maybe the
misunderstanding.
beauty of such webinars and maybe the beauty of ERN is something that we might change together, you know, even
Yeah.
if we need to change terminology. This is something that we should work on together, right? Because this is through our relationship, we might change something, yes,
I
and then lead to
totally
the
agree.
outcomes.
I see one
Yeah.
question.
No,
No,
it was
was
me. It
ask a
was me.
question. You was
Ask a question.
sorry.
If
No,
someone can ask some questions.
maybe you explained so well that there are no question about the question.
Wonderful. All right, that's even better.
No question about what to ask. But I think was very educative or informative, this discussion, because really sometimes it's very difficult to the start the relationship between the patient and the doctor. Sometimes, unfortunately, in the big hospital, you don't meet the same doctor where you create already a sort of a relationship. They know each other. And so the patients start again, and maybe not all the doctors have the same mood, the same behavior. So this is another limitation,
It's
a
another
barrier.
constraint, the changing of the teams. But I can say that patients are really resilient and are kind of used to that. It's not the very good, of course, but they are used to that. And sometimes I also hear a funny word. They say, "It's not my doctor, it's my team," because they know that doctor belongs to the team of his usual doctor, and they create sometimes not. It's good that you talked about that, Mauricio, because sometimes you don't create a relation with one doctor but with a team of doctors, or with an hospital. Sometimes I have patients that says to me here in our Lisbon city, I love Santa Maria Hospital. They say all the hospital because they have nutrition, they have doctor, nurse, or several specialties in that kind of big hospital, and they say that hospital, huge hospital, is my connection. So it's really interesting what you said. Sometimes the relation goes beyond just one doctor or my doctor. Sometimes we prefer doctors. That's true. We cannot deny that. Sometimes we want. I have patients that says, "I want the oldest doctor because this is too young," and I say,
It's
"Take it
true. This is true.
easy."
This is true.
Sometimes
This
that
is true.
happens. They
This is
have to
true.
create a relation with the younger doctor too.
Oh,
But
sometimes are much better. Sometimes are better.
yeah,
Yes, absolutely, especially regarding the updating about the disease. But at the same time, don't forget that the experience, especially when you talk with the patient, that you have heard a lot of histories, different histories, the experience. So the large experience sometimes is already a very good way to see a new patient because it's a deja vu. So you meet someone that tell you something that you know also the trajectory of the years, and you can already do a sort of preparation the patient for his future, for his therapy, better than when you are full of theory, full of lack of indexes of drugs, and you say, take this because this is new one, this new one. Sometimes the patient need also to feel the experience that is wiseness sometime, usually.
yeah.
And the
Sometimes
patient
that's
has a
important word.
perception of that, yes.
Yeah,
Yeah,
that's why we
but
build trust. Yeah, this is how we
yeah,
build trust.
trust. We talked about that trust. Sometimes I said older, but sometimes there are patients that like young researcher and young doctors because they are new. They have new ideas for my disease. My disease is
No
too
problem.
difficult. Sometimes they have that kind of commentary, but the main issue, like Magda said, is to have trust in the healthcare system or unit or professionals or team that are trying to be in team with the patient, because for me instance I work with palliative care, so the patient is in our team, so he feels really secure with us. Feels really in the same level, like I said, with the doctor, medical doctor, with the specialist, and we are really close to this kind of patients. So maybe we can steal some ideas in this specialty, multidisciplinary approach that really works really well. And we see that we have nice outcomes and a really nice improve in the daily life basis, especially in pain, controlling pain. We have a good and fatigue. That pain and fatigue are two
This is true.
major
This is true.
symptoms.
This is
Yeah,
true. But
and
there
we
are
have
two
a good
levels.
outcome.
But there are two levels of a rheumatological center. The center specialized in one or two disease, and the generic center where you see
Yeah,
any rheumatic disease. This is another limitation, of course, because if you get the right doctor with experience in your disease, you are lucky. But if you get a doctor in a generalized center where he is expert in another disease, not too much in your disease, here start some problems. So you understand the same team, same center, specialized or not, but a different attitude for the doctor or personal experience. So this is another reason for different probably outcome in the patient. So you must consider also this point that is very delicate. That's why some the patients say, I would like to be visited by doctor, because they already know or they already saw him as a team before, and they understood that he was just in his disease expert. So this is another variable. I can
And it's not easy for my country to found good experts in our MCTD disease because it's so rare, and we don't have here in this country a lot of specialized doctors or units, but who have the luck to live near Lisbon, it's the capital, or Porto, have a little bit more luck on that. But it's really hard. It's really hard for the patient to have in first time the diagnosis. It's a really difficult pathway because sometimes the symptoms are really hard to acknowledge and to get to the diagnosis. It's really difficult. Yeah.
Why I say that? Because the target of RecordNet is just to identify the specialized center where the diagnosis may be faster and the patient will be treated correctly as soon as possible. This is the target of RecordNet for rare or complex disease. Don't go around, but we know that MCT, the best center are X, Z, and
this.
The problem is at the beginning, who we will address to the center, and still the problem is a circle.
Of course, but it's really difficult with our kind of diseases. It's not it's not easy because sometimes patients don't search for a doctor because they think they are tired, they think they are depressed, they think they have this and this and that. So it's kind of a long journey to really meet a real expert. And that's why the job of the ERN Reconnect and the centers are really important for us, because that's why we are EPECs on this, because we need to get better diagnosis, faster diagnosis, and
expert.
And not be different to be in Poland or Portugal or France. We have to address patients and to give them some kind of hope.
Okay, I think we are on time, almost on time. I would like you, Vera and Magdalena, for this wonderful, passionate discussion. I thank all the participants and overall Emanuele. I want to see Emanuele is there because he's the hard worker behind the curtains that organize everything, as a lot of patience. Pazienza to keep everything running well. Thank you, Emanuele, very much for your thoughts. And I say to our participant, thank you again. And I hope this RecordNet webinar will have once in YouTube very soon, will be of interest for many other patients. Thank you very much.
Thank you so much.
Bye.
Yes. Have a lovely day.
Bye. Thank you.
Bye.